you, Cynthia. I'll join you with the table in a moment, but I have a better view of the audience standing here for just a moment. So thank you very much. A very interesting discussion regarding the paper. I really want to open this up to the roundtable and for discussion and questions. And once again, as you get to the microphone, please identify yourself. Rima will start first, but please identify yourself so we know exactly who is speaking. Rima?
Rima Rudd, a member of the Roundtable. I'll open with congratulations, Cynthia. This was a really finely written and rigorously developed paper. I was very impressed, and the reading was pleasurable. So those two things don't always go hand in hand. So again, congratulations for a fine piece of work. I'm curious about something, and I wonder if you would address that. Don Nutbeam, who is well known in health literacy circles, and who actually, like you, has both a practice. He was head of public health in England for a number of years before he entered academia. So he has that balance of practice and academic orientation. Did a review about a year ago and found 7 articles. You found 74, and I just wonder if you would take a moment to address the difference and how that came about, because I'm sure you read his paper and used that paper and was in some way.
Well, we actually started with that question ourselves. You know, were there only 7 papers really out there? And we posed that question to the committee fairly early on. We said, you know, do you want us to only find the same 7 papers, and do you want us to sort of define the field that narrowly? As I understand their parameters, he was using his framework of, you know, functional, interactive, and critical health literacy. And so he was primarily interested in finding those studies that he saw fitting at the interactive and critical as outcomes, right? So they were only looking at health literacy as outcomes. We obviously opened it up and said health literacy could be at any point in the intervention in terms of how you choose the people for your intervention, any way in which you want to measure it. So we said, based on the feedback that we got from the planning committee, that they wanted to have a broader look at the field. So that was sort of right from the beginning. We said we're not going to limit it to health literacy only as an outcome. And even when we looked at the 7 papers that they reported, the way that community was kind of used, it was used, and we comment on this in the paper, that they use the term community and population interchangeably, and for us, we said we're not going to do that. So you will notice throughout the paper, we don't talk about populations, we talk about community consistently. And community, we defined as having some element of groupness, right? So that's, and because basically we needed some way to distinguish what we called the individual interventions, some of which are in Nutbeam's report, and the non-individual interventions. So those, like the example that I gave you of having a community clinic where you recruit individuals, right, just because they happen to have received services at that clinic. They then participated in this intervention as individuals. The results are collected about them as individuals and then aggregated and reported in some way. So for us, that was an exclusion criteria if your intervention functioned that way. And so there had to be some kind of group dynamic. There had to be some explanation of why the community was chosen. Typically, it was because there was, the researchers said there was low health literacy, however they defined it. And that was part of it too, is we did not necessarily try and parse the intentions of the researchers. If they said that's what they were doing, we sort of said, okay, we're going to accept that and then look further at what you did in the intervention. So the intervention had to have some group component. There had to be some interaction. Now, what we would have liked to see, which we think would help, kind of expand the notion of community, was to explain what happened when you brought these people together, right? There was virtually no commentary in the papers that explained, we brought all these Latinas together for this intervention. What happened, right? Or we brought all of these, pregnant moms together and they were in this group for 6 weeks. Well, okay, what was going on between them for those 6 weeks, right? So that was part of our inclusion criteria, but we said it's kind of, again, a black box about what that group element was. But that was, again, sort of the way that we differentiated between how we got to 74 papers and they only had 7.
Which leads me just to make another comment about the coda, in a sense, some of these sidebars in the conclusion that you reached. I was really pleased by the attention paid to community engagement and the idea of community participation, that you emphasize that at the end. In many ways, to me, is part of the heart of health literacy, that sense of dignity, of engagement in dialogue, and I really liked that at the very end of the report. So again, thank you.
Thanks.
Michael?
Hi. So congratulations on this work.
Once again, please identify yourself.
Michael Pash-Orlo, Boston University. So congratulations on this work. It's really a good contribution. Two questions. First one is, because of the complexity of terms, community, I completely agree, and I'm very happy that you bring this out and bring out the fact that it's really complicated in many ways. People may be doing community research, community work without using that term. And then the same thing about health literacy. There's certainly, so maybe just to stop first for that question, probably you have thoughts about this because, this project is actually much bigger even.
Right. Yeah, it cuts both ways, right? So if you use the term community and we take a closer look and there's no community and we throw you out because of that, right? But then there's people who could be doing community and not using the word community, and maybe you should be in, right? But I think at some point we said, we've got to have some rules, right, to operate by, right? Any method is going to choose some things and not choose others, right? So what we tried to be we just tried to be as transparent as possible about the method so people could say, oh, if I were to replicate this, I would have used a different set of terms and maybe, included something that we didn't include. So there's always that possibility for sure. But I think having looked now at so many papers, I think I would ask, if you don't use the word community at all, do you actually have an idea of community, right? And I think that's what we were trying, that is the question I would put back. So I would be more reluctant to include papers that didn't include community than not. Does that make sense?
Right, but so the same thing also for health literacy, right? So people were doing interventions that maybe we would regard as health literacy work. So maybe you would say the same thing about that too. You have to make a definition, you have to have a method.
Yeah, actually, I think the more frequent thing that we saw, and that's how we went from 170 to 74, is that we would find that health literacy was in the title or abstract. Typically in the abstract, people would put it as their conclusion. So in the abstract, it would be in the conclusion section of the abstract. They said, this intervention increased health literacy, or this intervention can increase health literacy. And then we'd dig through the paper and we'd be like, where? Where is the health literacy piece here? So that was actually the more frequent problem.
No, I get that, but at some level, someone, for example, may be doing work to, increase the use of self-efficacy and teach back and this and that and the other thing that we would say, oh, these are techniques in the health literacy, but they're not using that word, so we don't find them in this way. Anyway, maybe just to move on to a different thing, which is that when you step back to 10,000 feet on this work. It seems like a fair amount of the interventions with respect to that people use this term, that the nature of their groupness also somehow focuses and connects somehow to vulnerable populations or poor populations. And so I don't know if, having now sifted through all of this, if you have any other additional comments, if these things work, why don't we use them on rich people?
Yeah, and that's why I opened with what I did, is that I think, people are looking at communities of greatest need, right? So if we're thinking about resource allocation, you could argue, the resources are being appropriately allocated because they're going to the communities with the greatest need. They're not going to Beverly Hills and trying to work on health literacy interventions in Beverly Hills, right? We didn't find that. So, but I guess, we didn't see anybody trying to define communities by SES particularly, right? You know, so saying we're going to choose like a variety of communities and we're going to see if this intervention works in sort of a high SES community, a medium SES community, a low SES. They would just simply say, this is a community where there's, you know, large number of people with low health literacy, and that's where we're going to do our intervention. So I think that's a very worthwhile question to discuss, is saying, should we be trying this in a greater range of communities with, you know, broader range of SES levels?
Right, or if there's if there are other things that we're doing in those other places, why don't we do them in low SES places too? So, but it goes both ways.
Yeah, we just did not. I mean, they may be there, and maybe they're called other things, but we just didn't find them.
So to Michael's point, if health literacy is really the ability to communicate about health information and understanding and services, perhaps all communities really need the focus. Correct? It's whether it's
they may need them, but the gradient is different, right?
The gradient
Who needs
is different.
them more? And I think that was where everybody sort of started their papers. These are the communities that need this the most, is sort of how most of the papers opened. You know, we're going here because, you know, the epidemiological data say go here, right? Or we've used certain measures and determined that the need is greatest here. So.
Bill?
Bill Elwood from NIH's Office of Behavioral and Social Sciences Research. I apologize for being redundant both with Rima and Michael and what I told you before we started, but yes, it was a joy to read, and the methodology is meticulous, and you and your team have made a substantive contribution, not only in the community-based context, but I think for health literacy research in the future.
Thank you.
I am, something you said at the end really struck me, and I think relates to partly Michael's question, in which you questioned including knowledge when measuring health literacy. And if health literacy is the ability to access information, process it, and act upon it to make decisions appropriate to yourself for your health care, why would there, although there is a difference between health education and health literacy because it is the ability to act upon it, why wouldn't we look at people's health education levels, particularly if they're living in Beverly Hills, because it's not simply the epidemiology that drives health literacy. It's also what people know, and sometimes what they know is inaccurate folk wisdom or inaccurate information rather than the facts.
Mm-hmm. Yeah, we actually argue that we think knowledge should be still considered an important outcome. I think we were somewhat in dialogue with the Nutbeam paper that Rima referenced on that point because, you know, they say that's why they basically looked at interactive and critical as their outcomes and didn't look at functional, right? So that was in part, I think we were sort of reclaiming knowledge and saying knowledge still should be in the spectrum. Sure. So we would agree with you.
Jennifer? Jennifer?
Jennifer Dillahay. I'm a member of the Roundtable and with the Arkansas Department of Health. I thought it was really helpful to make the distinction between health education and health literacy because I think health literacy level predisposes people as to how easy they can receive and gain in terms of health education interventions. And it seems that that's a fundamental skill set. One thing, though, that was interesting to me is this, if you would comment on this, is many of the chronic disease interventions seem to be oriented around certain chronic diseases, and then people will call it diabetes literacy or diabetes health literacy and so forth. And it seems to me that those tend to be more about health education as opposed to health literacy interventions, and I wonder if you would comment on that.
Yeah, it was the same struggle that we had with the mental health. Well, I mean, I think the chronic disease and the mental health sort of share that. We also saw that with nutrition literacy. You saw people kind of talking about nutrition literacy frequently. I think we thought it was better to bring that body of work to you all and say, what do you think, than to necessarily exclude it, right? And have this conversation about, do we want to draw the parameters? How do we feel about people kind of parsing this and talking about diabetes literacy and nutrition literacy and cancer literacy and sort of all these variants, mental health literacy? Do we think that's a good thing? Do we need to be partnering with them? Or do they mean the same thing? If they mean something different, how do we engage them in what we mean? So I think we said, we're going to take them at sort of, like we said, we're going to take them at what their face value, at their word, or what they said they were doing. And so they would oftentimes interchange. They would talk about health literacy at the same time they'd talk about diabetes literacy, or they'd talk about health literacy and they'd talk about nutrition literacy. So we said, let's just put this out there. It felt like it met those other criteria, the inclusion criteria, so we weren't sort of, artificially stuffing them into the pile. But, that this would be the kind of discussion you'd want to have and say, well, do they mean the same thing, and is that a good thing for us or not, right? How do we engage them? And I think we make the point in the discussion that a lot of what we found, to me, sort of opens up the space because people are publishing in so many different journals. We tried tracking different fields, but that was not so easy to code. But there's a lot of outreach we could be doing, right, beyond, our sort of merry little band here. There's a lot of outreach and engagement we can be doing as scholars and practitioners, too.
Thank you.
Well, my name is John Gardner. I'm retired from CDC, National Center for Health Statistics. And one thing I noticed over many years of looking at statistical research, that in health and other areas is there's a tendency to look for your watch under the street light rather than where you actually lost it. And the thing that concerns me in a discussion like this is the lack of attention to affective aspects. So people may have high or low health literacy, but if they have no motivation to apply health literacy to their own or their community's situation, it doesn't seem to me likely that there will be a strong positive outcome. Another affective thing that comes to mind here is we talk about communities, but people are defined by parameters of a community, not necessarily by identification with that community. And it would appear to me that perhaps a degree of affective identification with the community would have a lot to do with the efficacy of community interventions. Would you please comment in general on the affective or motivational aspects of the problem?
Well, I'm not entirely sure that I understand the question, but while you were talking, I was thinking about one of the studies that we found early on that we spent a lot of time talking about, and it was a dementia intervention with 3 Aboriginal communities in Australia. And it is, the paper itself is just the evaluation report. It wasn't about so that we had very few details about the actual intervention, and we couldn't find the original paper about the intervention itself. But they go into great depth talking about the effect of this intervention was to open up a conversation in that community about a previously difficult topic. So there had been people in the community acting strangely, right? So that's how the community interpreted it. There were people acting strangely. And they didn't have a kind of a concept or vocabulary to talk about what this strange behavior was. But once they did this dementia intervention, people were like, oh, okay, so that's why so-and-so is acting the way that they do, right? And so it kind of opened up this whole space. And then one of the kind of unintended effects was a group of elders that they showed this dementia intervention to said, oh, is that what you think is wrong with me, right? So are you telling me that I have dementia? Is that why you're showing me this DVD now? And so, we had a hard time kind of describing, what in sort of, as you said, how do you describe what that effectiveness meant? I mean, clearly it had a very positive, quote, effect in the community, but how did I translate that into the kinds of effects that I thought that this committee was asking us to report about? But we tried to take those kinds of reports of effectiveness seriously too, and it seemed to me, if I understand your question correctly, is that that was sort of a great exemplar of community engagement at the sort of most detailed level, because the community, I mean, because the way the intervention happened is it was just sort of available truly in the community. It wasn't just a very small subsample of people who, you know, there was an exposure arm and a non-exposure arm. So I don't know if that addresses what you're talking about or not.
Well, you addressed the second part, the community identification, and
Okay.
thank you very much for that. Let me very simply re-emphasize the motivational aspect. There are many people in health communities that I'm aware of in my age group where people are very literate about the need for physical fitness and sensible diets. But they don't do physical fitness because it's uncomfortable. I don't enjoy it, so I don't do it. I know that I should be eating better, but I just don't like that food. So the motivation to employ health literacy knowledge can overwhelm any effective health literacy in my observation.
And I think most people agree with you, and I think that's why we would invoke like health behavior theories and other kinds of theories that would get to those motivational questions.
In addition, we'll have discussion later about implementation, so that may answer some of your questions in addition. Yes.
Hi, my name is Donnie John. I'm the Executive Director of NovaScript Central. You talked about the 5 categories for framework, and sustainability was one part of the framework that you couldn't find a lot of information. So outside of research, when we have to actually implement these projects, you know, it's always the ROI discussion. You know, how can you make sure that we're getting the return for our investment? So once the grant dollars expire, how do you scale the project? Even for CDC grants, if you want to do it on a large scale, it's always about you do a pilot project and now let's scale it. Was there any discussion in your evaluation in terms of some programs that could have shown a little bit of success or reasons why they weren't sustainable? Because during that pilot program, yes, you have the grant dollars to make it, hire everybody you need, get all the tools, but then once it all, you know, goes away, you know, you're back at square one.
Right. Trying to think. I would think that probably and I'm trying to, I don't recall the details, but, you know, so for example, the Ophelia model that Richard Osborne is doing in Australia and other places. My understanding of what they're trying to do is that there is a sustainability component to that. I don't recall a discussion of that, though, and, you know, maybe Richard's listening and maybe he'll, you know, send in comments about that. But you know, I think most people just said, you know, we're thinking kind of very traditionally. It's like we're going to run this intervention, we'll look at outcomes at 6 months, maybe 12 months, maybe 18 months at the most. But they just didn't even comment about like what that sustainability might be. I mean, if I recall correctly, that UK intervention that I mentioned, like the self-care for the people, there was some discussion, I believe, of sustainability there. But you know, I can't really speak to the mindset of researchers about why they didn't address that. I just know that we didn't really find much evidence of sustainability.
So one of your exclusion criteria was not looking at the type of providers delivering the intervention. So do you think if you incorporated that in the next go-around in terms of looking at the type of providers where, for example, with Medicare, you can bill for chronic care management visits where it doesn't have to be the physician providing the education, but it could be ancillary staff, nurse, pharmacist, whoever, that they could still bill for that service. So there's a potential of, you know, sustainability when you can actually have someone pay for it.
Well, and I think that would be sort of similar to the discussion we just had about health education. Would we want to count every sort of counseling intervention as a community intervention, right? Because that's what a lot of those turn into, and that's what we saw in many cases. There was an intervention, a diabetes intervention called Star Mama, and we went back and forth about whether or not it would stay in or not, but it was mainly about training promotoras, you know, community health workers, to do this individual follow-up with people. So yes, I mean, when you have that kind of individual level data and you're in a health system and you're tracking people over time, okay, then maybe you can have that. But I think you'd have to talk about, do you want to count a one-on-one counseling intervention as a community intervention? For us, we said that it just didn't look like, there was, again, it was just mainly a recruitment issue. We're, quote, recruiting from the community, but we couldn't see what else about it was a community component. So we talked about those 3 papers that we found that trained dental students, pharmacy students, and I can't remember the third one, but there was a third kind of student that got trained. But the results were mainly focusing on the effects on them as providers, not so much on the community, right? So the community was sort of there, I don't want to be dismissive, but almost kind of like as an afterthought, right? It was like some place for the providers to do the work, but they didn't really report on the effects, quote, on the community members themselves. So it's possible if there was really sort of that dynamic between the two and the intervention was really looking at both and reported about both, then yeah, sure, that would make sense to include that.
Thank you.
This next. Yes.
Türkan Gardinier from Pragmatica. Very impressive presentation, and I'd like to follow up on the outcomes aspects that you started talking about in terms of value added. And I'd like to add the term comprehensibility, because we attended a workshop presentation relative to the desirability of returning the results of genomic analyses to individuals from whole genome sequencing, where the terms are incomprehensible even to the researchers. And there was a discussion relating to value subtracted in terms of not having people understand what is being presented to them and getting scared and not coming to any follow-up, perhaps counseling meetings. So I think in terms of presenting the outcomes of some laboratory analyses, we should put emphasis upon how the people are going to use these results. Diabetes is a well-known term among individuals. They know about hypertension, hypoglycemia, hyperglycemia, but in terms of results of genomic analyses, I don't think people would understand unless there's an intermediary process of translating the relevant material in terms of highlights to what is meaningful to them.
Well, that's why we had that content. So in our 4-part structure, so people were taking care of issues of comprehension with how they designed the content.
Oh, wonderful.
And I think the other thing is we included in that section that we called, papers of interest, but were excluded for various reasons. We cite 3 papers that talked about reporting results back to,
oh, wonderful.
Or 2 or 3 papers that talked about reporting results back to communities. But I think a lot of people in this room might disagree with you that people know what diabetes and hypertension and cardiac disease are. I mean, I think that's what the chronic disease paper showed, is that most of these communities, they were starting at a very low level of knowledge, even about what we take to be common health issues.
Thank you very much.
We just have time for people who are at the podium, so we'll have the 3 at the podium and then go on to the next. Bill?
Bill Elwood on the round table, NIH's OBSSR. I think particularly Donnie and for everyone, when it comes to the literature, first you often have to get through peer review to get your grant money, and then you have to go through peer review again to get your manuscripts revised, resubmitted, and finally, we hope, accepted. And there is only a limited bit of time space for that to happen. I think that the change NIH changed its rules for human subjects. We call it clinical trials research in 2014. It goes into full effect in the new calendar year, which will require the posting of listing all social and behavioral interventions. And as time goes on, with the milestones set partly by the grant structure, PIs will have to post their protocols. At the end of the studies, they will have to post their data. And so not only will it obviously help with recruitment, but also it will be a great way to disseminate information. It also will be considered in the review of peer-reviewed journal articles, because the authors will have to reference their registered clinical trials number in their paper submissions. So just as currently authors sometimes provide supplementary data to a journal article, in this case, reviewers and eventually readers can look up that clinical trial and see, for example, if the results they're pointing out are listed in their primary or secondary aims. I think we're about to see a tremendous expansion of the availability of information and a much broader and also deepened discussion about research, its results, and diffusing it across all levels of the American people, not just the research community.
Thank you, Bill. Ruth?
Ruth Parker. Hi. Thank you, Cindy. Great, a lot of work there. So I have a specific question about the search strategy.
Okay.
So if I just step back from this and say, before I read it, what are the interventions that I know of that I would call community-based that relate to health literacy? I don't see them on the list.
Okay.
Okay, so that makes me worried. So it's a very specific question. If I read this correctly, health literacy and community had to be in the abstract. I don't think those terms are in the abstract or the title of those articles. And so
the ones you're thinking of that were excluded?
Yeah.
Yeah.
And so I just wanted to ask, if you didn't have that as an exclusion criteria and went with the search terms, if you feel like this would have cast a different net and what that means and how I use that when I think about it.
So what terms would you have used instead?
I would not have looked specifically at terms in the abstract, to be included in the abstract and in the title per se. They would have been search terms.
Well, they were terms that also appeared in the, in the article itself, right? I mean, but when we got those 2,400 results, when we did the title and abstract review to go on to the next level, we had to have some way to say what would distinguish this as a health literacy intervention.
So let me press you there.
Okay.
I agree.
Okay.
So this is where I'm wondering. So the things, for example, that targeted diabetes or mental health or, name your entity, but didn't have the terms health literacy and community in the title or the abstract, even though they applied to content that some of us might look at and say, oh, this relates.
But like what, can you give me a specific thing? Like, are you thinking like...
I'll follow up, but I just wanted to make sure I understood the methodology well enough. Those terms, those two terms had to be in the title and had to be in the abstract.
Not in both.
Either, one or the other. Okay.
Or like health literacy could be in the title and community could be in the abstract, or community could be in the title.
But both words had to appear
but they
somewhere.
had to appear somewhere because, otherwise it's like what else could, then you'd have to have like a list of techniques. Then you could say, well, I'm going to search on, and people could say, well, those techniques count or those, again, there was no sort of, there was no consensus list of things to start with. So we felt like we were asked to do a review of community-based health literacy interventions, right? So those seem to be the key terms that people were looking for in this topic area.
Right. One other question. Do you happen to know impact factors of the journals that you included? Do you have any sense of them?
No, there was a very wide range of journals, but we did not track that, no.
Thanks.
Yeah.
So thank you very much. The questions were interesting and stimulating, but Cynthia, thank you and your team. You really began the day with a wonderful and stimulating discussion, which really set the foundation and framework for the rest of the day. So we thank you very much, not only for coming, but the presentation.